everyone, happy morning, a very good morning. I hope and I believe all of you are doing well. Am I audible and visible to everyone? Hello everyone, happy morning. I can see that yes, I am audible and visible. Just give me a quick thumbs up so that we can proceed ahead with the session. Now, okay, all right. So in the today's session, we'll be seeing the signs in respiratory radiology, a review of the signs that we have learned earlier, plus some new signs as well. And like your last session in neuroradiology, where we had a bonus extra edge sign at the end, we have one extra edge image coming at the end of the session. So stay tuned till the last because I want to see who gets the diagnosis right in that case. All right. And so we'll start with the respiratory radiology signs, and tomorrow 9 a.m. okay, so tomorrow 9 a.m. we will have the third session in this series, the signs in radiology, and that will be your gastrointestinal radiology. Okay, gastrointestinal radiology. And 5 p.m. we are going to have today's session on the app, which is going to be a free live class, and it's going to be integrated radiology MCQs. Okay, so 5 p.m. it's your integrated radio anatomy integrated clinical questions in radiology. That is what we'll be having at 5 p.m. all right. And there are some new things happening on the platform. Plus subscription, we all know. Iconic, we know. And we also know that Iconic prices have slashed. So this is something that we have introduced recently, and that is a 4-year subscription, right? So till now we had 3-year subscriptions, but now catering even to the first year MBBS students, we have the 4-year subscription which we have introduced for both Plus and Iconic, and that too at a very, very reasonable price. Plus a very, very exciting feature introduced on the platform, only on the Plus platform, is raise a hand feature. So now you can raise your hand and you can speak to the educator during the class. You can get your queries solved personally, and there are a lot of things happening on the Plus platform as well, right? And you have the new batches which are starting on 23rd of June. The NEET PG batch is starting, where you will have high yield topics revision, test and discussions, PYQ, images discussion, and also the third prof batch is starting on 23rd of June, which is for 1 year. That would be catering to ENT, Ophthal and PSM. Okay. Now this we all know 3+1 and 12+2. So guys, whenever you are subscribing to the platform, you can use the code Dr. Nikita Live, and I'll be happy to see you all on the platform. Now let us start with the signs in respiratory radiology. This is the first sign here. Tell me, what do you see here? What is the sign that we are seeing here? Yes. So why everyone is talking about the tram track sign? If you are confusing this one, which looks like a bronchus, it is not a bronchus. Actually, this entire thing is a mass here, and you can see this air in this mass as a crescent above. This is air crescent sign. Okay, that's your air crescent sign, not the tram track sign. This is the air crescent sign. Now, two signs which we read very interchangeably, we use the term air crescent sign or the monad sign. But when you go into the details and when you read about them, it is said that air crescent sign is seen in your angio-invasive aspergillosis, while your monad sign is seen in aspergilloma. That is what the books say. So when you see this air crescent sign in the angio-invasive aspergillosis, there will be the infarct, angio invasion hota hai, infarct hoga, and when the patient develops the immunity, then there is this appearance of air, there is retraction, there is invasion of neutrophils, there is retraction of this nodule, and you will see the air crescent sign appearance. So this air crescent sign is basically a good sign in angio-invasive aspergillosis. It indicates that yes, the patient is developing immunity. While the monod sign in aspergilloma, so you have a pre-existing cavity like TB ka cavity, and isme there is this fungal ball coming and surrounding that, which also looks like the air crescent, that is your monod sign. So how do we differentiate between the two is, for your monod sign aspergilloma, if you do a prone CT, right, if you do a prone CT, this fungal ball will move to the dependent part. While in your air crescent sign, recovering angio-invasive aspergillosis, this is not a mobile thing. This will not move. While in the prone CT, this will move. Okay. So remember that air crescent sign, angio-invasive. So air AI से आप याद कर सकते हो. Air crescent sign is specific the terminology used for angio-invasive, and monod sign is for your moving fungal ball. Okay, monod sign is for your moving fungal ball. So these signs we use interchangeably, but ideally we should not. They have been described as separate one. Okay. Next one, what do we see here? This is the second sign here. What are we seeing here? Yes. So here we are seeing the horizontal fissure, which should be here. It is bulging down like this. So this is your bulging fissure sign, right? This is your bulging fissure sign. And above the horizontal fissure, we know it is the right upper lobe. So there is this opacity in the right upper lobe. Okay, all this is the opacity in the right upper lobe. But we know that consolidation ideally should not cause the structural shift. Here we are seeing that it is bulging down. Now this was classically described in Klebsiella pneumonia, which causes very viscous mucus wala sputum hota hai. That causes the pressure on the fissure and the fissure bulges down. So it was classically described in Klebsiella pneumonia, but then later on it was found in other causes as well, like Haemophilus pneumonia and others. So if asked only one of the best answers, then the answer will be Klebsiella pneumonia. That's your bulging fissure sign. Okay, asked frequently in your exam. Yes. Next one. So this is something, a new sign maybe that you would be reading. Now when we want to differentiate whether the mass on the chest x-ray, now though we have CT scan which is so easily available. Previously when the diagnosis used to be made just on the basis of chest x-ray, whether this mass is in the anterior mediastinum versus in the posterior mediastinum. So there are signs that we look for, and this is one of that sign. What is this sign? No, this is not your Pancoast tumor. Pancoast तो आपका specifically इधर आएगा lung apex में, right? Very correct, absolutely right. So that is called as your cervicothoracic sign. Okay, that is called as your cervicothoracic sign. So what happens? Your anterior mediastinum, it ends at the level of clavicle, while your posterior mediastinum, it goes above the clavicle. So if you see that a mass is going, if these are the clavicles, okay, if these are the clavicles, and you see that the mass is going above the clavicle, it has a well-defined border above the clavicle, that tells you that this is a posterior mediastinal mass. While if you see a mass which is just ending at the level of clavicle, it is getting merged with the soft tissues of the neck, then that mass is in the anterior mediastinum, like we are seeing in this case. So you can see that यहाँ पे right side में एक mass है. It is not going beyond the clavicle, and on the CT scan coronal you can see that these are the clavicles here. Look at the mass here. It is just ending at the level of clavicle. In the axial CT, we see that this mass is anterior to this. These are the branches of aorta. This is the vein here. So this mass is in the prevascular compartment, that is in front of the vessels. So you know that this is the anterior mediastinum. So now with CT scan it is not a problem. We can easily see whether this is anterior or posterior. But in the good olden days where there was no CT scan, based on this कि clavicle पे mass खत्म हो रहा है, the upper border is not well defined, it is merging with the neck and the soft tissues, then it is your anterior mediastinal mass. Okay, that is your anterior mediastinal mass. So, and the posterior mediastinal mass will extend above the clavicle and it will have a well defined upper border. Okay, so that is your cervicothoracic sign. Absolutely right, Ritvik, very correct. So similarly, we have many signs, which help us identify where is the mass located: the thoraco-abdominal sign, the Hilum Overlay sign, the Hilum convergence sign. We'll be seeing that as well in the upcoming sessions and towards the end of the session. As I told you, the last image is something where I am excited about to see who gets it right. Yes. Okay. Let's go to this one. Now, what do you think? Is this mass anterior or posterior mediastinum? Based on the cervicothoracic sign, what do you think? This mass is anterior or posterior? So you can see that it is going well above the clavicle. This is the mass here, well above the clavicle. It is causing the shift of the trachea as well above the clavicle. So this becomes your posterior mediastinum, and this mass on histopath was your ganglioneuroma. That is a neurogenic tumor. Most common posterior mediastinal mass is your neurogenic tumor. Okay, so it is going above the clavicle, right? What sign is this? What is the next sign here? What sign are we seeing here? You have the arrows marked here. Yes, that is your comet tail sign. Okay, that's your comet tail sign. Very good, Chandan. So comet tail sign is basically seen in your round atelectasis. We have discussed this in our classes as well, like your asbestosis. So it is also called as round atelectasis, also called as your folded lung. So you have the area of pleural thickening. Okay, you have the area of pleural thickening. It causes the lung invagination jaise. That is the rounded atelectasis. Collapse pulls the structures towards it. So all these which you see here are the vessels which are crowded towards this round atelectasis. So this is called as your comet tail sign, or also called as crow feet sign. Okay, it is also called as crow feet sign. So remember that it is seen in your round atelectasis, not specific for asbestosis. It might be seen in tuberculosis also and other conditions. But comet tail sign is asked in your exam and it is important. So remember, what forms the comet tail is basically the pulled vessels towards the round atelectasis. That forms the comet tail sign. Okay, that forms the comet tail sign. Yes, your comet tail sign on ultrasound of abdomen in gallbladder, it is seen in gallbladder adenomyomatosis, where the cholesterol deposits in the wall, they give the ecogenic artifacts. You get this linear ecogenic artifacts, the comet tail artifacts from the gallbladder in gallbladder adenomyomatosis. Okay, so let's go to this one. What do you think is the sign here? So I would rather say there are two signs here, one this one and this is the second one. There are two signs here. Very correct. So we can see that there is this continuous diaphragm sign, very well seen here. In between the heart and the diaphragm there is this black air. So that gives the continuous appearance of the diaphragm. Normally in the central part, the diaphragm and the heart, they are close together. So we are not able to differentiate the central part of the diaphragm. But now if surrounding the heart there is the air, then the diaphragm is separated and we can see the continuous diaphragm sign. What is the importance of this sign? Continuous diaphragm sign. If you see that, it differentiates your pneumomediastinum from pneumothorax. So this is air surrounding the heart. That is either pneumomediastinum or pneumopericardium. When you are seeing that there is so much air going in the other parts as well, then you know that this is pneumomediastinum. And here what you see is in the pectoralis muscle, these black lines, that is the air, that is called as your ginkgo leaf sign, right? That's your ginkgo or ginkgo, whatever you want to call it. That is your ginkgo leaf sign. So the ginkgo leaf looks like this and it has the striations like this. So that is the black air, that is your ginkgo leaf sign, and this is your continuous diaphragm sign. Pneumomediastinum, best investigation air will be CT scan. Okay. Next one, what sign is this? What sign is this? Yes. So there are ground glass opacities, but apart from that, we also see this linear things, right? Those are the interlobular septal thickening. So you have the lobules which have the ground glassing, and you have the interlobular septal thickening. So this is classical your crazy pavement sign or the crazy paving appearance, and it is basically when you have ground glass opacity along with interlobular septal thickening. Multiple causes. The prototype is pulmonary alveolar proteinosis, but now it is also seen in this era. Remember COVID-19 mein, it is a very frequently seen sign. It is basically your GGOs along with interlobular septal thickening. You can just get an image on this key, identify the sign. Is it honeycombing? Is it your crazy paving? Is it consolidation? So that is your crazy paving. Okay, there are multiple causes of that. Anything which fills the alveoli and it causes your interlobular septal thickening, alveolar proteinosis, it can be your hemorrhage, it is COVID-19, can cause your crazy pavement appearance. Right. Next one. Okay, so what do we see here in this one? So you have a nodule. Okay, that's the nodule there. And this white thing, the linear thing, that is the vessel going to the nodule. So you can see the vessel going to that nodule. What is this sign called as? So that is your feeding vessel sign. Okay, this is your feeding vessel sign. Feeding vessel, you can see that the vessel is feeding the nodule. What does that signify? What does that signify? The feeding vessel sign? Absolutely right. So the feeding vessel sign basically indicates that this is a hematogenous spread wala nodule. This nodule has come there because of the hematogenous spread, and that is your very commonly seen in septic emboli. Septic emboli, आपका hematogenous spread हो रहा है. Might be seen in your pulmonary like hematogenous metastasis as well. Pulmonary secondaries, pulmonary infarct. So it basically indicates your feeding vessel indicates hematogenous origin. Okay, that was your. What's the triangle? That is the arrow which is put there. Okay, it's nothing, it's the arrow which is put there. Basically, the triangle is showing the nodule and the arrow is showing the vessel going to that nodule. Okay, all right. Let's go to this one. What do you think is this image showing? This is like the classical on the left side. This is the left side. This is classical on the left side. What are we seeing here? But look at the classical shape of the consolidation that we have here. What is the shape of the consolidation that we have here? The classical shape, that is your triangular shape with the base towards the periphery, the triangle towards the central part. So this is basically your pulmonary infarct. Okay, that is your wedge shaped. Absolutely, that is your wedge shaped pulmonary infarct, and that is your Hampton's hump. Okay, that is your Hampton's hump. So when you see this peripheral wedge shape opacity, always think of pulmonary infarct, and if you make a diagnosis, you can really save the patient's life by giving thrombolysis या thrombectomy करके. So identifying Hampton's hump pulmonary infarct is very important. Peripheral wedge shape, like we have seen on the chest x-ray, right? So you get this wedge shape opacity peripheral, that is Hampton's hump. This is also Hampton's hump, that is pulmonary infarct. Okay. Next one, what are we seeing here? So you have two arrows pointed here, one here in the upper zone and one arrow is pointing here. What sign is this? Absolutely right, it is collapse. But what sign are we showing here? What sign is this? What sign is this called as? So diaphragmatic tenting, that is called as your juxtaphrenic sign. Okay, this is called as your juxtaphrenic. That means adjacent, phrenic matlab diaphragm. So diaphragm ke baaju mein, that is your juxtaphrenic sign. And this is basically in a patient of tuberculosis. This was a patient of tuberculosis where we see the upper zone mein fibrosis hai, and that collapse is causing the pull here. Basically it is because of the inferior accessory fissure which gets distorted because of the collapse, and it gives the juxtaphrenic sign or the juxtaphrenic peak sign. So it is seen in your upper lobe or middle lobe collapse. Okay, it is seen in upper lobe, middle lobe collapse, or even after your lobectomy, your post upper lobe lobectomy, that gives your juxtaphrenic sign in upper lobe and middle lobe collapse. The peak like thing that you see here, juxtaphrenic peak sign. Okay. Next one, I have already given you the clue there. What is this sign there? So I'm sure we all have had this in our childhood, or we might be having this even now. So this is your Polo Mint sign. Okay, that's your Polo Mint sign. So like the Polo Mint, you have the periphery, beech mein khali hai और periphery में ये white है. So center is empty and surrounding it is the white thing like you are seeing here. So this is where you see कि बीच में it's black and surrounding is the white thing. So this can be seen in basically your any vessel thrombosis, predominantly venous thrombosis. The center is the thrombus and the surrounding is the enhancement, the peripheral enhancement of the vessel. So like here in this right pulmonary artery branch, the center is the filling defect, that is the thrombosis, and surrounding it, that is the enhancing part. Similarly here we are seeing the Polo Mint sign here affecting which vessel? Affecting which vessel are we seeing this Polo Mint sign? So this is your ascending aorta, this is your pulmonary, and this is your superior vena cava, right? The structures are SAP, we have discussed that. So this is your SVC thrombosis, superior vena cava thrombosis, showing the Polo Mint sign. Surrounding may white contrast or center is empty. Now similarly here, where do we see the Polo Mint sign? It is here that we see, okay, this is the white thing and this is the thrombus. This is your portal vein. Okay, this is your portal vein. So we can see in portal vein thrombosis, SVC thrombosis, pulmonary artery thrombosis, anywhere basically where you have the filling defect, that is the thrombus, and surrounding enhancement, that gives the Polo Mint sign. Okay, that's your Polo Mint sign. Okay, let's go to the next one now. I think this should be an easy one. What is this? So if I can zoom this image for you to show you this sign better. Absolutely right, that's your Signet Ring sign. So you can see this black color is the dilated bronchus and this chota sa is the normal sized artery. So look at how your bronchus is larger than the artery. It has to be at least 50% larger than the artery to call it bronchiectasis. So this is the dilated bronchus. This is basically your Signet Ring sign. Okay, this is your Signet Ring sign which is seen in bronchiectasis. Okay, which is seen in bronchiectasis. Best investigation for bronchiectasis, HRCT. So you have the larger bronchus and you have the vessel there that gives the Signet Ring sign. Yes. The other sign seen in bronchiectasis, you have the tram track sign. You can get in cystic bronchiectasis, you can get the bunch of grapes appearance where they can show you the air fluid level as well. So you can get bunch of grapes, tram track, Signet Ring sign in bronchiectasis. Where did we read the Signet Ring sign in your nephroradiology? In the recent FMG LMR series, we discussed the Signet Ring sign on IVP. Nephroradiology, Signet Ring sign on IVP is seen in Signet Ring sign on IVP, where you have the central non-enhancing part and you have the surrounding area containing the contrast. Absolutely right. That is seen in papillary necrosis. Okay, that is seen in papillary necrosis. Next one. Okay, so we are here to the last image. Okay, so after this I'm going to show you for this patient. So this was basically a patient who had just come for a health checkup, x-ray, chest x-ray, and incidentally this mass was noted. Okay, so incidentally there was this mass noted on the right side. What sign are we seeing here? Yes, that is your, so we are talking about your Hilum Overlay sign. What is Hilum Overlay sign? So these signs are basically based on the silhouette sign. What is the silhouette sign? If you have a mass here and you have the structure here, normal structure here. If they both are abutting each other, then this structure will be obliterated. If you can see the structure well, that means this mass is not abutting this structure. It is either anterior or posterior. So this is for to know whether the mass here which you see, which looks like a hilar mass specifically, is it actually a hilar mass or is it an anterior or a posterior to it? Now if in this mass you see that this is labeled here, this is the mass here and you can see these vessels, okay, the pulmonary arteries. They can be seen well through this mass. It is not obliterating these pulmonary arteries. So you can see the pulmonary arteries through this mass very well. That means this mass is not abutting the pulmonary artery. It is anterior or posterior to it. Most commonly it is anterior. So that rules out that this mass is proper in the hilum. When it is obliterating, it can be like your hilar lymph nodes, okay, like that. But here it is anterior or posterior. The best thing, easiest thing that we can do next is your lateral radiograph. Where are we seeing here? The mass is located here, okay. This is the mass which is located here anteriorly, right? It's not posteriorly. So then we got to know ki yes, this is an anterior mediastinal mass. This is not your middle mediastinal mass at the hilum per se, because you can see the vessels through it. So this is your Hilum Overlay sign, okay, overlay. So you are seeing the vessels through it. The hilum pe vessels are seen. So that is the Hilum Overlay sign. And when we did MRI, this is where the mass is located. Okay, when the MRI was done, this is where the mass is located. So now this is what is the extra edge question here. Can you make a diagnosis? Can you make a diagnosis what is this mass which we saw on the chest x-ray? What do you think is the diagnosis here? So first what do you need to do is first identify whether this is CT or MRI, right? This is MRI. You can see this vertebra ka black cortex. You can see the vertebra ka black cortex. Now identify whether this is T1 or this is T2. How will you identify? Look at the water part of it. So look at the CSF surrounding the spinal cord. Here the CSF is white. So this is T2. Here the CSF is not white. This is the fat. Okay, this is not CSF. यहाँ पे ये काला काला rim है surrounding the spinal cord. This is T1 weighted. Now I have given you the major clues here. I've already given you the major clues. कि this is the appearance of the mass on T1 and this is the appearance of mass on T2. So what do you think is the diagnosis? This is not thymoma. This is very correct. Absolutely right. So this is not aneurysm. This is not cyst. So Ritvik has put it as right thing. Absolutely. So you can see that the mass is white on T1. It has the white areas on T1. It is white. It is hyper intense on T2 as well. So what is white on both T1 and T2? That is your fat. Most important thing we think of is fat. Or it can be hemorrhage as well. Which stage of hemorrhage? Like your subacute hemorrhage is T1 white. So what is the next step that we can do to differentiate कि ये fat है कि ये hemorrhage की वजह से white है? You can take a MRI sequence which is your fat suppressed sequence. You can have a sequence. If it is fat, it will appear black. If it is not fat, if it is hemorrhage, then it will still look white. So if it becomes black on a fat suppressed sequence, then yes, it is fat, and the diagnosis in this case is mediastinal lipoma. Okay, that's your mediastinal lipoma here. That's your mediastinal lipoma. So if you have a look at this mass, on the radiograph as well, look at how it is more black. Okay, the fat is black. It is not very dense. Look at, it is not very dense like your soft tissues. It is relatively black. So that is your clue even on the x-ray that this is your mediastinal lipoma. But of course, you need to confirm it on cross-sectional imaging. So remember, T1 white, T2 white is fat, subacute hemorrhage. Do a fat suppressed sequence to differentiate between the two. Okay, so that is your mediastinal lipoma. All right. So yes, guys, that was about the today's respiratory radiology science. I hope you found it useful. Let's just have a quick review. First one, air crescent sign, angio-invasive. Monod sign is your moving fungal ball. That's the air crescent sign. Bulging fissure sign, let's remember Klebsiella for our exam. Cervicothoracic sign, mass ending at the clavicle, that is anterior mediastinum. Cervicothoracic above the clavicle, that is your posterior mediastinum. Comet tail sign, round atelectasis. Then you have your continuous diaphragm sign. You have the ginkgo leaf sign. Pneumomediastinum, pneumopericardium also can give the continuous diaphragm sign, but not pneumothorax. Then you have the crazy pavement. You have ground glass with interlobular septal thickening. Feeding vessel sign, which shows that it's a hematogenous origin wala nodule, septic emboli, pulmonary metastasis, or your pulmonary infarct can give this sign. Hampton's hump, wedge shape, pulmonary infarct, look for pulmonary embolism. Then your upper lobe fibrosis with the diaphragmatic tenting like this, juxtaphrenic peak sign, upper lobe, middle lobe collapse. Polo Mint sign, you have the central filling defect with the peripheral enhancement, vessel thrombosis. Okay, vessel thrombosis like the portal vein thrombosis here. Signet Ring sign, bronchiectasis. And you have the mass, the Hilum Overlay sign. If you can see the vessels well through the mass, that means it is anterior or posterior. Hilum Overlay sign. If it is white on both T1 and T2, think of a lipoma. Okay, think of a lipoma. All right. So thank you everyone. I hope you've got to learn new points as well. And I hope this is a quick revision as well. Tomorrow 9 a.m. we'll be having gastrointestinal radiology science. And today 5 p.m. we have integrated radiology MCQ discussion. Integrated clinical, integrated radio, anatomy integrated. So today 5 p.m. it's the free live class on the app. Whenever you are joining, you can use my code Dr. Nikita Live to join the sessions on the app. All right. So thank you so much everyone. Goodbye. Take care. Keep studying, keep revising and keep winning and have a very productive